Hello, and welcome to the CAP Today webinar for Wednesday, November the 6th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host and moderate a question and answer session along with one of our guests from LabCorp after we hear our formal presentation. Today's webinar is entitled Tumor Diagnosis Recharacterization, enabled by comprehensive genomic profiling, powered by PGDx to guide precision medicine strategy. And as you'll see, we have a label on the actual presentation, which we will also read out to you as we begin our introductions. This very important and timely webinar is made possible by a special educational grant from LabCorp. We want to acknowledge that, and we want to thank LabCorp for their support and help in enabling us to bring you this important session. Our speakers today, and I'll say more about them in due course, both work at PathGroup. Dr. Michelle Shiller is the Medical Director of Genomics and Molecular Pathology Services there. Dr. Ann Carr is the Assistant Director of Bioinformatics at PathGroup, and we're delighted to have both of them lecturing. In addition, in a moment, I'm going to introduce you to Dr. Jennifer Jackson, who's with LabCorp Oncology, and she's going to be helping introduce and will join me in the question and answer session later on. And so to begin, I want to introduce, as I mentioned, a very special guest, Dr. Jennifer Jackson. She is a PhD and the Director of Translational Science and Strategy at Personal Genome Diagnostics and LabCorp Oncology. She received her PhD in biochemistry and molecular biology from Emory University and trained in the Department of Surgery doing a postdoc on circulating DNA as a biomarker for early cancer detection. So she's very highly qualified, and I'm delighted to have her here. And once again, let me read this title slide, and I'll pass it to Dr. Jackson. Beyond therapeutic selection, comprehensive genomic profiling for current and future applications in precision medicine. And with that, I will ask Dr. Jackson to begin. Dr. Jackson.
Thanks so much, Bob. Appreciate the opportunity to speak to everyone today. Good morning, good afternoon, depending on where you're calling in from. And thanks for joining us today on the CAP Today webinar sponsored by LabCorp Oncology. As mentioned, my name is Jennifer Jackson. I'm the Director of Translational Science and Strategy at PGDx, which is now a part of LabCorp Oncology. Today we'll be hearing from two exceptional speakers, Dr. Michelle Shiller and Dr. Ann Carr from PathGroup, which is a reference laboratory headquartered in Nashville, Tennessee. So they'll be speaking with us today about their experience with the PGDx elio tissue complete assay, which is the backbone of PathGroup's Endeavor test. This test is a comprehensive genomic profiling assay intended for use in identifying clinically actionable biomarkers that can help guide therapeutic decisions for cancer patients. Moreover, they will share insights into how this test has helped confirm tumor diagnosis and, in some cases, which will be highlighted today, has better refined or classified tumor indications to unveil new therapeutic opportunities. So before I hand it off to our experts, I'd like to provide a brief intro to PGDx, again, now a part of LabCorp Oncology. We were acquired in 2022 and brought into the LabCorp Oncology fold to further enrich the cancer diagnostic portfolio of products. With a shared vision of bringing the promise of precision medicine within reach of all cancer patients, we're developing a comprehensive portfolio based on leading-edge scientific innovations with the ultimate goal of empowering better outcomes for patients. Bringing together both our centralized and decentralized models through laboratory services and kitted solutions, our goal of bringing precision medicine to all and delivering impactful experiences for both physicians and patients remain the cornerstone of our collective business model. So to orient everyone to the PGDx-based testing options available through LabCorp Oncology, here I'm providing a quick view into our kitted solutions as well as our centralized testing services. On the left side, you'll see our kitted solutions enable molecular pathology laboratories to internalize comprehensive genomic profiling in-house, in order to provide testing options to physicians and patients locally. Within your own CAP/CLIA laboratory, pathologists can empower local insights by running the FDA-authorized PGDx elio assays for both tissue and liquid biopsy genomic profiling, using the power of robust chemistries as well as bioinformatics developed by PGDx. By internalizing these kitted solutions, samples and clinical data are maintained on-site, benefiting both the patient and the physician by enabling rapid turnaround time to results. Both the Elio Tissue Complete and Elio Plasma Focus DX are FDA-authorized kitted solutions and can be run clinically on-site in your own laboratory. Additionally, and not mentioned here, the PGDx Elio Plasma Complete assay is a 500-plus gene liquid biopsy kitted solution that can be run in your laboratory and is currently available for research use. So switching over to the right side is our complementary centralized testing services, where institutions that may not yet be ready or not yet equipped to internalize complex molecular profiling have the option to send out testing to LabCorp oncology sites. So currently, the PGDx-driven solutions that are available, or at least coming soon, are the LabCorp Plasma Focus LDT and the LabCorp Complete LDT, both liquid biopsy-based solutions to help guide therapeutic decision-making when tissue is limited or not available. Additionally, the LabCorp Plasma Detect, which is a tumor-informed MRD LDT solution, will soon become available to help detect cancer relapse in select indications. So overall, LabCorp Oncology strives to meet the institutions where they are in their complex molecular testing journey in order to enable broader access to critical testing for cancer patients. So briefly, I want to expand into our FDA-authorized kitted solutions. I will go into each of these assays in a little more depth. So in 2020, on the left side I'm referring to, we received FDA clearance on the 500-plus gene PGDx Elio Tissue Complete assay. This is a DNA-based NGS test which queries a wide variety of somatic variant classes and is able to identify clinically actionable as well as relevant biomarkers in order to help guide physicians toward personalized treatment strategies. From sample to results, turnaround time is as low as 4 days, and with the FDA authorization of this test, labs can launch this clinically in their own laboratory after a simple assay verification rather than a full validation, which can take a lot of time. Through great efforts working with commercial payers, we've received a dedicated PLA code to support billing with a coverage of close to $3,000. More recently, and really excited to share here today, in August of this year, the FDA granted de novo marketing authorization to the PGDx Elio Plasma Focus DX test. This is a 33-gene panel, and it's really focused to query key clinical biomarkers that can help guide physicians and treatment decisions. This is the first and only pan-solid tumor liquid biopsy kitted solution of its kind. So again, the turnaround time from sample to results is as low as 4 days, and this test allows for variant detection down to 0.1% variant allele frequency. The chemistries of both of these assays are consistent, allowing for the easy integration of complex molecular workflows in your local laboratories. So together, these complementary solutions allow physicians to maximize the amount of genomic information they're getting and then gain more comprehensive insights to optimize individualized treatment plans for their patients. And with that, I will hand it back over to Bob to introduce our next speakers who will be presenting on their work using the PGDx Elio Plasma Complete assay in tumor diagnosis recharacterization.
Thank you, Dr. Jackson, and that's a wonderful introduction to some of the very latest and most up-to-date offerings. We're going to hear more about them now. And let me introduce our two very distinguished speakers. Dr. Michelle Shiller almost needs no introduction. We've worked together many times in CAP Today webinars and other places. She's globally recognized as a thought leader in molecular pathology, and she has built some very high-performing teams in that subdiscipline of pathology. After receiving her DO degree from the University of North Texas, she's become quite expert in integrating the clinical use of molecular diagnostics, focusing on utility interpretation and the application of complex testing to the benefit of patients. In addition, Dr. Shiller and Dr. Carr are going to go back and forth today, so I'll introduce them both at the same time. Dr. Shiller is now joined by Dr. Ann Carr. Dr. Carr is a PhD, and she's the Associate Director of Bioinformatics at PathGroup. She trained at North Carolina State and then subsequently at Vanderbilt. She knows a lot about RNA sequencing, comprehensive genomic profiling, and targeted DNA sequencing. So we're very delighted to have them both. And with that, I will invite Dr. Shiller to begin today's presentation. Dr. Shiller.
Thank you so much for that humbling introduction, Bob. And it is just wonderful to be here today and to speak with everyone. Those of you already working with next-generation sequencing platforms in the space realize that really we as the pathologists are just that end face of a lot of this. And our team that works amongst us joined here today with Dr. Carr are actually even more important than me. And so I am excited to partner with Dr. Carr in this presentation. I also want to endorse that PGDx and LabCorp have been great partners with us in this kitted assay. Should anyone have questions, I do want to endorse them as great partners in internalizing such testing as we did here at PathGroup. So our focus today will be tumor diagnosis recharacterization enabled by comprehensive genomic profiling, CGP to be short, powered by PGDx to guide precision medicine strategy. And internally, we call this assay Endeavor. So just to do a level set, because I appreciate that the audience may include all kinds of skill sets, I thought it would be nice to walk this through how a patient actually comes to our care. So with the very beginning, the patient will present somewhere in a clinic, in an emergency medicine facility, with some sort of chief complaint or something that has changed in their life. This could be blood in their stool or dyspepsia, also known as reflux or acid reflux kind of feelings, difficulty swallowing, jaundice or being yellow and discoloration, shortness of breath, cough, or coughing up blood. And any of these will lead to a more extensive workup by our clinical colleagues. And ultimately, in a lot of cases, particularly when a lesion is identified through imaging that would subsequently occur, tissue is acquired, and hence then the journey begins with us in our laboratory space. So next, the specimen goes to the Department of Pathology, and ideally that front-end conversation as to what to do with the specimen, depending on how it's acquired. If it's not an attended biopsy, which data shows, at least specifically with lung cancer, but it can be generalized, that having an attended biopsy in the interventional suites does increase yield for testing downstream. But nonetheless, the specimen is placed in formalin, then it gets into the laboratory and is grossly examined and described. If it's a biopsy, we even enumerate how many pieces we have, we measure them, and to describe them and understand what we start with. It gets processed and stained, and then those slides are taken to the pathologist, who will examine it, start making their impression and differential diagnosis, and then do additional studies to help rule in or out different entities as they're going along their journey, including immunohistochemistry, FISH or fluorescence in situ hybridization, and a variety of different molecular assays. If we're in heme specifically, we might also add flow cytometry and other cytogenetics karyograms. But for molecular testing in specifically hematologic malignancies and central nervous system malignancies, the final diagnostic rendering through surgical pathology requires some level of molecular analysis. And also with endometrial malignancies, as per NCCN guidelines as well, this is requisite for ultimate risk stratification for endometrial malignancies. And I will just posit that this is the journey which we are going on across all types of solid tumors. In addition to that, when I speak with pathology audiences, I try to encourage participants to transition from rendering a malignant diagnosis and moving on to the next case, and instead pausing and thinking, what happens next? And want to encourage the thought of, to begin with the end in mind. Where is this tissue ultimately going? What is next for this patient's journey? When that might be unclear, I encourage people to get a free subscription to nccn.org, which is how you access the NCCN guidelines, where a lot of the discussion is documented around relevant biomarkers, etc. So further along in the pathology journey for the patient, I'm showing here this diagram that many of us know and is near and dear to our hearts. This differential diagnosis, this workup, the CKs are cytokeratins, and that helps us to distinguish that we are in an epithelial derivative of the tumor. Then we have other markers like PSA, prostate-specific antigen. When it's positive, that's helpful to distinguish it's a prostate cancer, but we all know that not every prostate cancer is going to express that antigen, and there are others to add into the workup. So this is just a basic sketch. Then a lot of times we'll use TTF1 as a delineating factor that will help us to get into the category of lung and thyroid, but may, if it's negative, may not be as helpful. We find ourselves often on this far right branch point that has a yellow circle around it, where we have a CK7 positive lesion and otherwise negative, including hormone receptor negative, which still doesn't rule out a breast cancer because it could be triple negative, or an ovarian carcinoma that has gotten so high grade that it no longer expresses other antigens on the surface, and leaves us with a pretty broad differential. Further to that, and curiously, I'm not seeing the build, so what I had in the earlier iterations of this was a gradual build showing some of the different NCCN guidelines, first starting with non-small cell lung cancer, but you see listed here on the left-hand side of the slide, non-small cell lung cancer, biliary tract cancer, muscle-invasive bladder cancer, prostate cancer, pancreatic adenocarcinoma, and colon cancer, all listed. And there are others. I just wanted to start giving the idea that comprehensive genomic profiling is very commonly referenced in the NCCN guidelines for advanced cancers. And this slide is here to elucidate that. In addition, as we think about when to utilize comprehensive genomic profiling and what its place is in the marketplace, there was this wonderful paper published in the JCO. It was a consensus opinion with a collaboration between the Association for Molecular Pathology and the American Society of Clinical Oncologists, or ASCO. And they came up with a provisional clinical opinion making a lot of statements around the use of these assays and these tests. And I encourage you, if you haven't read that, to grab it and take a look at it. I took a few quotes directly from that paper to really help guide our thinking with it. One of them, and the first one on the slide, is patients with metastatic or advanced cancer should undergo genomic sequencing in a certified laboratory if the presence of one or more specific genomic alterations has regulatory approval as biomarkers to guide the use of or exclusion from certain treatments for their disease. Another meaningful quote taken from the paper, multi-gene panel-based assays should be used if more than one biomarker-linked therapy is approved for the patient's disease, and I'll elaborate on that even more momentarily. And then lastly, site-agnostic approvals for any cancer with a high tumor mutation burden, mismatch repair, protein deficiency, of course that's assessed by immunohistochemistry or loss of protein expression, or neurotrophic tyrosine kinase domain NTRK fusions provide a rationale for genomic testing for all solid tumors. So right there alone, we are beyond one genetic biomarker for any tumor that is advanced. Treatment selection, including efficacy of the potential therapy and functional impact of genetic change, also should be considered when doing the testing. So I decided to create a summary slide for the tumor agnostic approvals. As just mentioned momentarily, MMR loss of function, again, that's performed by immunohistochemistry. It's not a genetic biomarker, but it is one with a tumor agnostic approval. Microsatellite instability high is done through genetic testing, tumor mutation burden high, and we need a large panel for that. BRAF V600E mutation, RET fusion events, and NTRK fusion events. So when you just include microsatellite instability from the first bullet point and the subsequent 4, that's definitely more than one genomic biomarker. So you can see where there's a strong evidence and a strong use case for utilizing broad genomic profiling for advanced cancers. I want to also pause for a moment and and point out the fact that there is a pan-tumor approval for MMR loss of function, microsatellite instability, or TMB high that all points to the same immune checkpoint inhibitor therapy, because what I see a lot is PD-L1, another biomarker that qualifies patients for immune checkpoint inhibitor therapy, being ordered, and I think it's just gotten tied onto that because it's the same drug that has this pan-tumor approval, but there are specific tumors where we have more data that we can tie with a PD-L1 expression. So PD-L1 does not have a pan-tumor approval. And then lastly, on this slide added this year was a pan-tumor approval for HER2 IHC3+ using the gastric 2016 scoring criteria. And for all of us in this meeting today, we can appreciate what a huge approval this was because we are so familiar with HER2. So internally we called this, or I called it Project Hercules, because it is a Herculean effort to try to get consistency with such broad use of something that we have such a very specific understanding of and overcame a lot of hurdles with, particularly with breast cancer, bringing our prototype there. Other pan-tumor approvals are under consideration, so please be aware that the clinical trial space is very active looking at that. It's my pleasure now to turn it over to Dr. Carr to continue the discussion today.
Oh, thank you, Michelle, and thank you, Bob, for that wonderful introduction. So as Jennifer mentioned previously, at PathGroup, we use the PGDx ileal tissue complete kit to perform comprehensive genomic profiling on all of our solid tumor specimens. It has coverage of over 500 genes. This includes most exons and splice sites, and it also has assessment of tumor mutation burden and microsatellite instability biomarkers per the NCCN guidelines. One of the really great things about this kit is it does include the FDA-cleared bioinformatic analysis pipeline, so you don't have that twinge of panic when you have to think about incorporating a new kit and redesigning all of your internal elements for analysis. We are active users of this kit, and our experience has been that it has been seamless and really efficient to integrate into our internal processes for report generation. And again, it's your samples, it's your data. We can confirm that. We maintain access and ownership of all of our data, and we can confirm some of these statistics described within this slide that attest to the assay quality and the reimbursement rates. So we utilize the PGDx Tissue Complete kit as a component of the Endeavor Solid Tumor Test. And the Endeavor test essentially integrates the comprehensive genomic profile findings, such as point mutations, indels, copy number variants, translocations, and fusions with molecular pathologist expertise, complementary guideline-driven testing, such as FISH or IHC if it's warranted, to create comprehensive reports that really optimize treatments for patients. So currently, the Endeavor test is still relatively new, but we have performed already over 10,000 tests. Here you see internal distribution of disease states for submitted specimens that we receive in-house. And one of the pretty surprising things here is the significant proportion of submitted specimens that are first diagnosed as cups or of unknown primary sites, about 15% of our cases so far. And this really had us curious about the impacts of comprehensive genomic profiling and how it can potentially influence disease diagnosis and patient care. So we decided to design a case series to essentially answer that question. So the objectives of this case series were to investigate cases where comprehensive genomic profiling molecular results resulted in either the refinement of initial cup disease diagnosis, the reclassification of initial diagnosis to a new indication, and to identify potential gains to patient care. And so we're just going to go ahead and dive right into some of these outcomes. So we identified a subset of cases, or essentially a molecular cohort, that we believe represent common examples of internal cases where comprehensive genomic profiling was really driving changes in final diagnoses. And this is a Sankey plot, which we feel really just nicely visually represents some of these common reclassification and disease refinement events that we experience pretty routinely. So on the left, you'll see the original primary diagnosis with the submitted specimen. And then on the right, you'll find the new final diagnoses post-Endeavor testing. And if you just follow the really nice color-coordinated branch points, you can kind of elucidate which cases sort of ended up with what final diagnoses. And this table, I know it's a little busy, but the most important thing here is that it does list all of the variants that are identified that did support the change in the disease classification. Oops, I'm a little pointing right here, if you can all see my pointer. The red dots on the left, again, are going to represent those primary diagnoses that accompanied the submitted specimens, and then the green are the updated final diagnoses post-Endeavor testing. And then the really important item on this, which we've boxed in right here, are all the FDA-approved therapies that were gained post-variant detection and post-disease refinement or reclassification. So if you kind of envision, if we hadn't run comprehensive genomic profiling on these samples, most of these columns and rows here would have been blank. So it's sort of nice to see them nicely filled in as a result of comprehensive genomic profiling. And as mentioned earlier, we kind of wanted to ascertain any potential gains to patient care, and a large factor in patient care is going to be therapy selection. So we performed a pretty extensive literature review of all of the available clinical trial data and essentially modeled for a subset of these cases for potential improvements to patient care. So this graph, I know it's sort of busy, but each one is set up in a similar format. So on the top left corner, you'll see basically the disease state that is being described within that box. And on the right, you'll see the biomarker targeted therapy that is associated with that disease state. The x-axis is going to be the mean progression-free survival, and on the right is going to be the percentage of grade 3 or higher adverse effects associated with all the therapies within that bar chart. The black and gray bars are going to be standard therapies, and then our nice colorful green, blue, orange, and purple bars are going to be those biomarker targeted therapies. And you can see pretty clearly that, gains in variant detections and improvements in disease classification, pretty substantially increase the mean progression-free survival for a lot of these disease states. And we did think it would be great to kind of jump into a couple of examples from this case series. So if Michelle, if you would like to walk us through one or two.
Yes, thank you so much, Ann. What a wonderful discussion we're having today. So yes, I thought it would be wonderful to highlight how this pans out in the hands while we're actually working through the cases. So you can see here that what we received were some biopsies of brain tumor, and you see ultimately that a diagnosis of poorly differentiated carcinoma was made. When you look at the panel of stains, you can see that a wide net was cast, and you see melanoma markers such as melanoma cocktail and SOX10 are negative, but the patient had a history of melanoma in the past, so certainly that was on the radar. You see Oscar and CAM 5.2 as positive. For those that are not as aware, those biomarkers would put us into the carcinoma category. You see other markers negative, including TTF1 ruling out lung, thyroid, CDX2 ruling out colon, PAX8 ruling out anything of a Wolffian Müllerian origin, GATA3 for bladder, PSA for prostate, and then here we have both CK7 and 20 as negative. So the best that we could go, or the pathologist could go, was with poorly differentiated carcinoma. So then when we got the results, what we found and what we received was TMB high, BRAF V600E, CDKN2A with a truncating mutation, and then in the back end, because our report is designed to pull forward treatment-related findings, so in the very back portion of other genes that were mutated, partially contributing to the tumor mutation burden high, but in the background as well was a TERT promoter mutation. And given this history of melanoma, this caused me great pause. And it's also important, we all know in pathology, that melanoma is known to be the great masquerader. So I contacted the signing pathologist for additional history to clarify, and additional workup confirmed no other tumors. Additional clinical dialogue rendered probably favoring melanoma even more so, because they were already somewhat suspicious. The non-small cell lung cancer squames typically do not have a BRAF mutation. That's very uncommon, nor TERT. And then an adenocarcinoma of the non-small cell lung cancer category typically does not have a TERT promoter mutation, just to consider some of those non-expressing lung cancers. So ultimately, you see a very elaborate clinical genomic pathology consultation. This is standard fare of what we do with our cases at PathGroup. We take the findings, we pull it together with the pathology findings, including the immunohistochemistries, radiographic information that we have on the patient, and we pull it together for the clinical provider so they have their high yield, what does the therapy, what are the mutations telling us about therapy at the top of the report, other additional ancillary findings as you progress along. And you can even note here PD-L1 was performed and seen as significantly expressed in this tumor, and then a summary of what is going on. And so you will see that we propose this to be in the clinical genomic pathology consultation a melanoma. And it's also noteworthy that, yes, melanoma indeed can express keratin. So it's one of those things that really just has to help us to keep things on our radar. And this one was hiding quite well because it didn't stain for any of the melanoma markers and decided to stain for keratins. So just looking a little bit more at the molecular biology and signaling pathways in melanoma, we know the MAP kinase pathway to be a common player here, specifically with BRAF mutations. But you can also see other mutations in the pathway. CDKN2A also is a relevant marker in the melanoma pathway, upregulating cell growth in an immortal way through both of those pathways. This slide is here to depict therapeutic considerations based on the findings in the tumor. So for this particular patient, giving it a melanoma diagnosis allows them to qualify for BRAF tyrosine kinase inhibitors, particularly in combination often with a MEK inhibitor. Now, if we were in a different tumor type, we do know that at least CDK4/6 and CCND1 have approvals for cell cycle inhibitors, and maybe an investigational consideration with the CDKN2A mutation here, but nothing in the approved setting. So definitely this helped to get the patient into a category that allowed them to be identified for a targeted therapy and to receive that targeted therapy, especially given their CNS metastasis. And then here's another case where that CK7 positive differential takes a key front and center role here. So what we received was a needle core biopsy with an ultimate diagnosis of adenocarcinoma, moderate to poorly differentiated. The CA19-9 was positive on this case, as well as the polyclonal CEA and the CK7. And all other markers, including hormone receptor expression, were negative. So when we got the Endeavor results, we saw that there was an IDH1 R132C mutation. Now, this is a very, very, very common mutation in intrahepatic cholangiocarcinoma and uncommon in other cancers that would be in this differential diagnosis. Further to that, the CA19-9 expression is typically expressed in pancreatic cancer or cholangiocarcinoma, and then also we had polyclonal CEA. That's fairly nonspecific, but all of this, in addition to the CK7, this IDH132C mutation, really points you to cholangiocarcinoma. Another common mutation in cholangiocarcinoma is, well, TP53 is the most common, but since TP53 is so widely mutated, that doesn't help us a lot, but it's ARID1A. ARID1A mutations occur in around 1 in every 5 cholangiocarcinomas. So this IDH1 R132C with a targeted therapy, as well as an ARID1A mutation and a TP53 mutation, all of this really points to cholangiocarcinoma. So clarifying this, again, also allows the patient to get therapy under an FDA-approved label. This slide shows you some of what I was summarizing in the previous slide here in a picture form, looking at the primary pathways involved in the pathogenesis of cholangiocarcinoma. And because I do believe we have some resident trainees attending today, I just want to point out it's always important to remember our cell biology, and I can already feel the groans from here. But nonetheless, yes, it's important to go at the molecular level, at the cellular level, understand what's happening. So remember that isocitrate dehydrogenase is part of the TCA cycle, which occurs in the mitochondria. So that is a mitochondrial process. And just for other inheritance notes, remember our mitochondrial DNA is maternally inherited. Just little additional educational pearls today. Then we have the MAP kinase pathway can be involved. We had an NRAS mutation in this case. You often may see mutations in the phosphokinase pathway, and it's important to, again, for the trainees on the line, to learn your pathways. For your MAP kinase, remember it's RAS, RAF, MEK, ERK, that's the pathway, or the proteins in the pathway, and the phosphokinase, PI3, K, AKT, mTOR. And here's a nice table, again, summarizing the prevalence of different genes mutated in cholangiocarcinoma, again, coincident with what we had in this case through the Endeavor testing. So we had a TP53 mutation, and their prevalence is the highest at up to 43%, but a pretty wide range. The next one in line is IDH1 at 22%, followed not too far behind and pretty closely by ARID1A, all of these being mutated in this patient's tumor. IDH2, BAP1, which is a BRCA-associated protein 1, and of note, ARID1A and BAP1 also are part of the homologous recombination repair pathway, and so you see accordingly therapies being investigated for that of the PARP inhibitor pathway. BRAF mutations at 7%, FGFR2, which we know also helps us sometimes to distinguish a cholangiocarcinoma, at 5% with the relevant tyrosine kinase inhibitors. And then HER2, looking largely at mutations here, and with the pan-tumor approval, you could also potentially identify the patient for antibody-drug conjugate therapy for cholangiocarcinomas. So hopefully it helps to really give a broader and deeper appreciation for cholangiocarcinoma at a molecular level. And it's also just important to realize that by considering this reclassification, patients are now identified for FDA-approved therapies or qualified for clinical trials, and helps us to understand overall the tumor biology. I can't overemphasize the importance of pre-analytics here. Optimal tissue handling from the very moment, begin with the end in mind. And then as you are assessing the case, to engage all of the players in the multidisciplinary team to really work together to arrive at the best thing for the patient, because as is seen here on the slide, and a repeat, but just for the points of emphasis, our patients benefit when they have the targeted therapies, when the tumor does have those available for treatment. So I'm going to go ahead and summarize today by again saying everything starts with the correct diagnosis, and sometimes, especially now that we're understanding tumors at a molecular level much more deeply, molecular really helps to tighten up that diagnosis for things that we can't see when we're assessing for protein expression. And the diagnosis will drive the surveillance, therapeutic selection, and prognosis. Here in these cases and in several other, comprehensive genomic profiling resulted in disease refinement and reclassification and identification of FDA-approved therapies and clinical trial identification. Use of comprehensive genomic profiling in solid tumor testing maximizes diagnostic and prognostic information to guide physicians and patient care. And what we're also seeing a growing use for CGP is clinical staging, particularly with non-small cell lung cancer, with biopsying of patients with multiple lesions and trying to understand what that represents from a staging perspective. Are these synchronous primaries? Is this metastasis of the same clonal process, et cetera? So I also want to acknowledge, again, as I started out, the entire team matters and is so important and vital to everything we do. A couple of key players to this project include Dr. Chris Coldren, Dr. Praneel Chandra, Dr. Bob Aber, Dr. Fazeh Kuistani, and Dr. Jennifer Jackson, in addition to Ann and I presenting here today. And you might look for more in the literature about that and about other projects discussed here today. So I will turn it back over to you, Bob, to field any questions.
Dr. Shiller, thank you so very much, and thank you to Dr. Carr. That was an extremely good presentation, and I want to just remind the audience now they can make comments and ask questions in the Q&A box that you see below the slide there, and we'll get to those. We've got some compliments coming through. I'll ask the first question, and then I'll ask Dr. Jackson to join me and pose the next question. The first one I think should be relatively simple. I'll ask it of you, Dr. Shiller. In your list of testing for different kinds of malignancies, you mentioned doing molecular testing, but on endometrial malignancies, you didn't mean to imply that you'd ever do cytogenetic analysis. Is that correct? I think you were referring only to hematopathology and those kinds of malignancies.
I was referring to hematopathology, yes. Great clarification.
Thank you very much. And now, Dr. Jackson, we have a very interesting question that I'll let you pose to both of our speakers.
Yeah, absolutely. And Michelle and Ann, great talk. Really compelling data that you've shown here today. And we have great questions coming in from our audience. So you mentioned on one of your slides that the clinical success of the Endeavor assay is at a rate of 92.9%. The question is what are some of the more common reasons for failures?
I can answer that one, Jennifer. So some of the reasons for failure really come down to DNA complexity and integrity. So, you know, some of those things occur during fixation of the block or, you know, staining. So we do try our best to really push through as many samples as possible. But the really great thing about having the Endeavor testing ordered is that, you know, in worst case scenarios where we are unable to complete the Endeavor testing, you know, we will reflex to other pertinent molecular tests that we think are going to be critical to inferring patient care. So hopefully that answers your question.
Absolutely. Yeah, thank you for that. We have some other questions, really more regarding some of the information that you shared on reclassification today. So how often do you find that molecular profiling results are conflicting with the initial pathological diagnosis? And Michelle, maybe this would be a great question for you.
Right. So rest assured, it is not incredibly common, and usually for actually conflicting with the diagnosis, it's very rare. So let's say it's probably less than 2% of the time. And any time that if it does do that, it's usually some very, very difficult case. I think I'd have to look back, but I would posit that 100% of the time it was a case that was sent in consultation with someone else. So these are very edge cases in terms of actually changing the diagnosis. What we see more often is assistance through molecular with those kind of unknown primaries, which the prevalence of the unknown primaries that we're receiving for testing represents 15% of the tumors. And how often we're able to clarify that, I'm not sure that actual statistic off the top of my head, but actually changing a diagnosis, it is rare.
Great, thank you. And that certainly aligns with the literature that, you know, albeit it's rare, it's a really critical feature that is not talked about a whole lot with comprehensive genomic profiling, that, you know, you can apply this to be able to confirm diagnosis and then in some of those more rare cases, overturn that diagnosis to find better therapeutic options for the patient. So another question along the same lines is, if this, this is certainly a rare situation, but what is the process that you or others are using to connect with the treating oncology or cancer care team? Are these kinds of cases automatically sent over to the molecular tumor board for integrated review, or how does that work? And Michelle, that'd probably be another great question for you.
Yeah. So typically what happens is there's often a discussion amongst the molecular pathologists within PathGroup just to establish consensus, and then contact is made most often with the signing pathologist. We receive most of our cases through our signing pathologists throughout the PathGroup network. So we'll connect with them and ask them what else they may or may not know about the case. If it's a case in Texas, because I'm part of the Baylor healthcare system, I can sometimes also look things up in Epic and help to facilitate things so I don't bog down our anatomic pathology colleagues that are so busy. Then typically the pathologist will connect with the oncologist. Sometimes they'll loop us in directly right away. Other times they may have the initial conversation. But nonetheless, it does end up going to the oncologist. It's typically not sorted through the molecular tumor board at any of our sites, but at our molecular tumor board, when it's a case within the Baylor Scott and White healthcare system, it is often subsequently presented for everyone to learn from it. So that's how it works with us.
Very good. Thank you, Dr. Shiller. Let me ask Dr. Carr, obviously with the scope of PathGroup, you're getting a wide variety of specimens from a wide variety of clinicians and care sites. Could you talk about the range of not only specimens coming in, referred specimens coming in for second opinions, and what tips you might have for those who are looking to avail themselves of your services as you've described them today? Dr. Carr.
Yes, so we get specimens shipped in from all over the U.S., and additionally, we'll actually have extracted DNA specimens shipped in internationally, which is kind of cool. I guess the most important thing is, just going to be communicating to your patient the benefits of comprehensive genomic profiling and ensuring there is, adequate tumor specimen to get it pushed through the pipeline to find results.
Thank you. Thank you very much. I'll just have a quick follow-up with Michelle Shiller. Dr. Shiller, you mentioned molecular tumor boards. How frequent are those boards in your experience and in your practice?
Yes, so we have one the first Monday and third Thursday of every month, so approximately every 10 to 14 days, depending on the month.
Very good. Thank you. And I just want to take a moment here. I can't resist. I understand that we have a significant number of Baylor residents in attendance today, and I want to give them, on behalf of CAP and CAP Today, a special recognition and thanks for joining us. I hope you're finding this very well worthwhile. So salute to the residents of Baylor. And with that, I'm going to ask Jennifer to give us the next question. Jennifer.
You bet. Thanks, Bob. So a very specific question about the research that you've shown today. With the case switching from non-small cell lung cancer to renal cell carcinoma, there was a loss of a MET targeted therapy option. As a physician, Michelle, would you recommend standard of care based on that new diagnosis, or consider treating the renal cell off-label for the new diagnosis?
Well, so I just want to clarify, because I'm not an oncologist, I will just support what the molecular findings say and confirm that from a genetic perspective and looking at clinical trial spaces that opportunity is available to the patient. and that the finding is a real finding. And then I do have to leave that final decision as to how the provider is going to treat that in their hands.
Great. Thank you.
Very good. Thank you. Thank you for that, Dr. Shiller. And let me just finally ask you one more question, if I may, Michelle. Tell me about in the curve of developments in this kind of testing, how important now are these new comprehensive genomic profiles to you to aid your understanding of these different malignancies and also help you in speaking to oncologists and others?
I love that question, Bob, especially because myself and probably many of my colleagues on the call today, I'm an old lady. I've been doing this a little bit. I literally, for the Baylor residents, they have to listen to me drone on because I can tell the story of how each biomarker approval landed and how it impacted the marketplace, et cetera. So the purpose of my sharing that is I have seen the evolution from initially single gene testing, where we literally just would test for one gene or two genes, to then small targeted panels, or a couple of genes and a small targeted panel, or a small targeted panel and FISH, which by the way still does have an important role. And stepwise walking through the headaches and the disappointments of quantity not sufficient for evaluation, and therefore patients having to go to cost and morbidity and time spent not having answers without therapy being started, all of those growing pains to get to comprehensive genomic profiling. And additionally, going through that and seeing the comprehensive genomic profiling, while a lot of people pay attention to the front page, I pay attention to the back page, because that's where we don't fully understand everything in the background all of the time, but there are definite patterns there that at some point will be extremely important for the patient. And I do see some early learning starting to occur, and that is part of something that could help inform staging sometimes when we have multiple biopsies, for example, in the lung cancer setting. So to me, I feel like it is critical, and it needs to be done appropriately and in the right setting, but it is pivotal in helping to understand the molecular biology of the tumor. When we have subsequent testing, a patient, perhaps we had the initial test, they were treated that finding, and they progressed, we can see and understand the molecular evolution of the disease, and I think it's pivotal to the forward progress. And if I may also, before I pause, with the molecular tumor boards, I just want to say that there's a lot of data to drive their value, and that they are more widely attended actually by our oncologists that we work with than the pathologists within our group. So for everyone out there, if you don't currently have molecular tumor boards, that is one way to get their attention and help them to learn to trust us and trust that we understand what's going on in this space and that we can speak their language. But it also is something that will help to change the face of the testing and increase that collaborative, multidisciplinary dialogue.
Very good. Thank you very much. I'll ask one final question, and I'll address it first to Dr. Carr and then ask Dr. Shiller to run the anchor leg on this question. Dr. Carr, what has been your experience right now, if you'd care to comment on it, and working with the PGDx teams, the IT, the customer support, and collaborations? Could you give us a little brief notes around your experience with this so far?
Yeah, so we've had a really excellent and productive experience working with the PGDx team. I come from a bioinformatics background, so I'm a data nerd, and we are often reaching out to them for access to our BAM files so we can dig deeper into some of these data sets to tease out these little nuggets of information. And, they're extremely responsive. They're extremely helpful. It's been really a great experience working with them, and we all look forward to see what we can develop together in the future.
Thank you very much. And Dr. Shiller, I'll give you the last word relating some of your experience now working with these teams.
Yes, thank you so much. So as I said in the beginning, they have been great partners. And I have to offer, I'm going to take this one here. I can be a little picky and I ask a lot of questions. So, but always in the spirit of helping the patient. And they always smile and they're always pleasant and they're always okay with my 985 questions about things. And can you look at this? Are we sure about that? They have been readily responsive, willing, positive, and if it's been uncommon that we've stumped the chump, so to speak, and not had an answer from them right out of the blocks, but when we have, when they've needed to kind of reconvene, they have always done so and come back providing more than what we even asked for in a positive way. So they have been great partners, and we're grateful to be able to work with them.
Dr. Shiller, thank you, and I'm sure they feel the same about working with you, and I know your residents are very excited. They're letting me know that, even as we know now in the comments and questions and chat that we enjoy here. So with that, I want to thank you, and let me begin to wrap up today. Obviously, I wish to thank Dr. Michelle Shiller and Dr. Ann Carr, both with PathGroup. They've given us a wonderful overview of these new offerings. It's going to be very exciting, and I'm sure that you'll want to review these, which you can do in about a week or 10 days at captodayonline.com. I'm sure you can bring your residents in and your colleagues in also to enjoy a reprise of this presentation. In addition to that, I want to thank Jennifer Jackson. Dr. Jackson has been a great partner today for her introduction and her help with the questions and answers. I really appreciate that. Finally, of course, I want to thank LabCorp. Their special educational grant made today's webinar possible, and I want to acknowledge that and, as always, thank them for their great support. Finally, I want to thank all of you in the audience. I know everybody's very, very busy now, and in the middle of the day, it's very gratifying to us at CAP Today that you can take some time out of your busy day to join us for these webinars. We're delighted to bring them to you, and we hope that you're enjoying them. We'd love to hear from you about them, and I want to thank you all in the audience. So just to sum up, thanks to Michelle Shiller, thanks to Ann Carr, thanks to Jennifer Jackson, thanks to LabCorp, and thanks to all of you in the audience. And with that, I'll bring today's webinar to a close.